Everything's okay? So we're going to get going again with our debates with the fourth key film, healthcare establishments. What are they for? I will ask Charles Guéprat, Elisabeth Hubert, Jérôme Nuzared, and Marc Penot to come up on stage. The moderator will be Jean-François Lemann. Please come and have a seat. So you can start the video now, please. In the 1960s, Madeleine has just been diagnosed with breast cancer. The tumor measures 3 centimeters. She's hospitalized for 12 days to have her breast removed. Bordeaux, 2017. A mammogram has revealed a small tumor in Laura. An operation has been programmed. She goes into hospital in the morning and comes home at the end of the day. With the increasingly less invasive operations and the growing popularity of outpatient surgery and home care, the conventional structure of hospitals and clinics seems to be crumbling as medical progress strides ahead. Given the extent of this progress, the days of the institutions at the core of the French healthcare system may well be numbered. Using the same teams, under the same roof, healthcare institutions can no longer continue to manage a kidney implant operation on the first floor or a drunken tramp rushed into the emergency ward for the umpteenth time, or the laundry operations in the basement. They need to refocus on their core vocation, surgery and complicated medical care. The hospital of the future will be less and less a building with beds and then a network of information and advice with data being transferred at high speed between hospital practitioners, clinics, and GP surgeries. The hospital and clinic of the future will be more than ever a place of expertise whose vocation will be to support patients along their healthcare path, even if the patients are not strictly hospitalized. There will be a permanent link with healthcare centers via telemedicine, while the famous French local hospital groups will be gradually transformed into local health care groups, as well as all public and private actors become part of the same dynamic. Whether care is in a hospital, at home, in a healthcare center, or in a clinic, the only way to fine-tune our healthcare system is to ensure a different sort of cooperation, free of suspicion or dogma. Each healthcare professional needs to play a role to match their expertise and in line with their new missions. Change is now. Hello, everyone, and good morning, everyone. We get the impression that everything has been said in the film. We're going to go on to something else, but no. There's a problem each year at the CHAM. We announce the death of the hospital every year. The following year, we come back with the same debate. Is the hospital dead? And we're going to do it again this year, and no, we're coming back to it again. But something has happened. There's been an explosion in the traditional political system. We had it in the spring. It's maybe a signal that things will accelerate as much as they can. So we gathered people who promise not to lie on this subject, but I'll try to ask people questions that are accurate. The hospital seems to be condemned, but it's keeping going. We're not going to lose time. You all know what everyone wants to say. I like coordinated debates, so we're going to start with a little poll. Here's a simple question, not for everyone, for our guests. The public hospital, in its version from the version at the early start of the century, is finished, and you can answer in four ways. Yes, yes, but, no, no, but. Yes, it's finished. So we'll start with you, Elizabeth. Yes. Yes, I've changed my mind since yesterday. Why have you changed your mind? Why? Yes, but I would say simply because the sense of hospitalization will not be the same as it used to be. That's a small yes, but, I would say. No, it's a yes. No, that's fine. Charles Guéprat, how about you? Yes, bet, yes, but we still need them for a little while. We're going to keep it for some time and transform them. Updating them, putting them into a network, and not having a competing system. So it's a yes, but. I'm taking note of that. Marc Penot, how about you? Yes. Yes, clearly. It's already personalized medicine is the future, and the personalized healthcare system is taking place. So we're not going to build any more new hospitals, certainly, or any new beds. long stay centers. There's going to have patients. We shouldn't have any more of these long-term facilities after 2035. We have to find other things, and it's not just a hospital. So it's a clear yes, yes. And Jérôme Nazaret, I don't know. I don't know if I'm qualified. So I'm from a clinic, but you, I'm not going to ask you about public hospitals. You mustn't come to debate. I can talk about the death of clinics. So I've been for 5 bins. 2 minus 2, it has been 2. 2 minus 2 equals minus 2. That's only politicians can. So your answer is, I don't know. There are people say yes, stop complaining. Your clinics are still doing all right, but other people say it depends on the shareholders. And the third people see the hospital is going to be there, but I don't know. So he just answered, I don't know. So we added up. We have 1 no. I wasn't a no. The same people thought the Berlin Wall wasn't going to come down. That's good. No but. That's people say, you never know. A good job. A good job isn't something you refused. Yes, but then there are people who can change their minds. I shouldn't have warned you yesterday. Yes, it's courageous, but somewhat timid. I don't know if in what time frame. I reserve my diagnostic on your presentation based on your future answers. You can't not answer my questions. So we're going to start with you. So if I understand, the hospital is dead. That's what everyone says. We've been talking about this for years. That's not the problem. The problem is that nothing is happening. So I had 3 hypotheses. Which is the right one? You started with the first one. It's perhaps the wrong idea, the wrong way of thinking. Is it an obligation? Is it the survival of this health system that's at stake? I have another interpretation. We don't want to look at reality. Is it an obligation? Do you think it's an obligation? Do you think that the system is in peril if we continue as we are? Mark? Continuing like this is preventing a care system from taking shape. If we look at some of the figures, yesterday we were talking about Sweden. If we just look at the health expectancy, life expectancy 73. We're a bit higher. We're at 75 years old, 65 years. We have to ask what the healthcare system must become. So the 50% of beds that we're not going to need anymore in geriatrics in 2035, that's going to be a good thing. But the obligation doesn't seem to be your preoccupation. So a transformation that's very difficult to do. It's a very complicated transformation. Maybe you can answer now. Do you have an idea of the time that it's going to take to do this change? We've gone to a lot of connectivity in clinics in sort of in 1 day. It was prepared, but we did it in the whole day. When we were aware, it can go very quick.
Ne vous inquiétez pas, j'avais fait parler personne, mais je vous réservais la meilleure pour la fin. Troisième hypothèse, il y a dans ce dossier de très mauvaise volonté, en particulier à la politique loco-régionale.
Particularly on the political side, you who were an elected official, are elected officials on a break? Well, I was more national than regional, but you were a deputy. So what I think is that it's a roadblock. Parliamentarians are something of a roadblock. I had put in an amendment that called on the hospital administration boards should no longer be the mayors of the cities. It was a great success. I think he had 2 or 3 parliamentarians supported my amendment. It was quite logical because it's always the same thing today. So what strikes me today, and this is something that we have to tie this in with what we talked about last night, something that Eric Ossan mentioned yesterday. I think that in the end, instead of we're in the society of mosquitoes, it would be, if we were mosquitoes, it would be much better. We would have had like 200 times, our lifespans would have gone by 200 times more quickly than we can today. That's to say that in clear today, you said it very well during your introduction, the temporality is always for tomorrow. It's So the people always have a little time to look to the future. So every year, yes, we say there's 3 or 4 billion of a deficit. We can absorb it, and so it's not so bad. And, there's a mandate that's organized, but with a certain degree of increases in spending, a few billion, But in the end, we can manage just about. I think and I hope that we're going to have someone who's going to interfere in the debate, and it's the patient. I think that the patient is going to come into the debate because they're going to have had enough to put them in the bed without other possibilities are mentioned. Whereas today, as the film said, people are aware that there are other methods. Let's not give us the whole debate. I asked you a simple question. You're brilliant, but you didn't answer it. So politics, if I answer correct, if I can just sum up what you said, we need to time, but the politics don't have. No, it's exactly the opposite. We don't have any more time, but politicians want to say that they have time. We can still wait for a little while. Politicians can drag their feet. Jerome, how about you? Politicians are also half responsible. He's not the one who's responsible for the budgets, but he's very involved in hospital management. So I want to tell you something. I've had several occasions where clinics and hospitals, we've had some very difficult times. The day where the mayor considers, so it's not one that's going to replace the other, and then we're going to have a common project, and things will advance very quickly. Yes, Charles? You have a mayor who's very active and very involved on the territorial development. So you were saying that the public hospital hasn't moved. I don't think that's really true. In 15 years, it has changed somewhat. It's changed its aspect. I hadn't said it hasn't moved. I said it's dead. That's different. But you said that nothing was happening. We have to recall that 15 years ago, there was no Valenciennes list. There were surgeries and maternity wards all over the place. There was an overall budget. But all this was absorbed by the system. And I agree with Elisabeth Hubert when she says that we have to go more quickly. We have to accelerate. 16 months ago, we already have a public group dynamic, which is quite measurable. If you look at it, it's concrete. So you can justify your opinion, which is your very opinion. So what establishments? You like Mrs. Thatcher, and we should privatize everything. Is that going to be our solution? You can say it can be done quickly. Let's say that tomorrow we privatize everything. In those days, I wasn't born, but I was already an old journalist in those days, so I can tell you what happened. Privatizing is good. It's in France. It's not the solution. On the other hand, in the last 10 years, we've been able to do private law with public rates. That's not privatization. It's real cooperation, and that can work. And the delegations, are you interested in that to take over a hospital that's not doing well? And in certain countries, like in Germany, yes, I think we're getting there, but I don't want to go back to this debate. We exclude, and that's not what we're claiming. That's what we're asking for. But the fact that you're not demanding it is one thing, but is it a possible solution? We're around this table to talk about solutions. I don't think so. So, Charles, we're going to talk about things more realistic than delegations and privatization. Hopefully, a good thing I didn't say yes. Given your comments, it's a good thing I didn't say yes. So we're increasing the resources. How about that? Nicolas Ravella said that there's going to be a larger budget envelope, and we're going to manage better. In particular, I wanted to ask you a question. The hospital package increased by some euros. Is it ridiculous to say let's increase it so that the hospital can be balanced in its budget? So it's 108 million euros on the national level that's going to be paid to establishments, but there's still something to be paid, but that's going to be wearing on the patient. So there are other solutions. Yes, but it would 400 to 500 million euros. That would be good. That would mean 6 or 7 euros per person. So it increases the hospital package, yes, by 20%. So that could be kind of a lot. We could ask, but the legitimacy of this measure. But do you need money? No. Of course we do. You said 400 million. I thought. But I think that there's a certain number of a certain maneuvering room that we have. It's not in the support services, it's not in the logistics, it's in our organization. So there's competition that we have with one another, and in the absence of real classification. So there's maneuvering room. We have a tour which is quite successful, and we're going to have an intelligent strategy for the group in the interest of the hospital establishments that are important in their perimeter, and it also requires a change and a more integrated vision of the population. So we have to manage things much better? No, it's not insulting. It's our job to do that. But there's still margin. There are avenues for progress, certainly. So you, Mark, it's another solution. So we do an inventory of fixtures, you could say, and we cut off the dead branches and figure whatever the consequences. No, it's not whatever the consequences. Okay, I'm being a little provocative. It's not necessarily on a financial level, but finances. It's not just finances that are going to resolve the problem. It's a question of medical democratics. Charles mentioned it's absolutely urgent care in a territorial manner, but not only, but between public health establishments. The public hospital must be open to the city. We cannot, by ourselves, find all the solutions to the stakes and to the challenges that are coming from demographics, as we mentioned earlier, on the evolution of elderly people or chronic illnesses. We have to find solutions for sharing and cooperation that don't exist sufficiently right now. So you said that we have to open up to the city, but I think we should have given place to a representative of a private physician in this debate, because it's fundamental that private physicians have to be organized as well in the territory. Otherwise, others will do it in their place. So for you, it's fundamental to have this link with. Yes, I think it's fundamental. So the problem today is the non-fungibility between the budget envelopes. I think it's quite clear that medicine, the day-to-day medicine that we have to follow, must include a kind of opening of the budgetary envelopes with some fungibility. So today, each gets their wager or what they're owed, and which hinders cooperation of the type GCS or private law with public pricing. In fact, that's a provision which could emerge or that exists already in certain areas. But here we're talking about the private medicine. I'm not talking about between institutions. So in private system, we have to look at the day-to-day medical care. So Elizabeth, would be to have hospitals only handle certain types of patients. I mentioned that you think that ambulatory practices are quite a good idea in your view. Can you give some details? That's what I said earlier. It was for certain, but I think we have slowly confounded hospitalization and hospital accommodations. So everything that we know about specialists, all the people here are specialists in terms of health. They know it, that we treat people differently, fortunately, from things that were the standards of 30, 40 years ago. So today we can use, and with all its added value, and whether the hospital, whether it's private, public. So the private hospital is, and you should say thank you, Jérôme, thanks to the financial constraints, it's been restructured more quickly. I think that. Do you have any figures on the hospital stay times for the same type of pathologies between? PVC gives the figures, yes, between how long people stay in hospitals and private or public hospitals for the same things. Some people would say it's not the same population groups. That's not the debate. But what I want to come back to is what I find striking is that we have, and quite recently, and even now, we have continued to build walls of hospitals with. Of course, I'm exaggerating about. I know that when I say that we haven't evolved compared to the past, but we're still building with one idea of accommodating people in hospitals. This has impacts in terms of costs, because building, with the investments that represents and the amortizations that's going to weigh on the hospital budgets, we have to pay them. And secondly, It means that we also, in terms of our organization of the work that people's there, if you have people who are in beds at night and they're perhaps going to stay for the weekend, that means you have to have service. You have to have service personnel and also care personnel. Once you have that situation, you have an organization, a work organization, that means that you have to have great needs in the terms of personnel numbers, and since there are constraints that have weighed on the hospital establishments, it results in suffering, which the personnel complains about today, quite legitimately. The organization, and if there's a place and a subject on which we're putting money, yesterday we had a debate that was interesting about it.
It's on that subject that we have to focus. So one, we've got to be more restrictive with the buildings. We've got to modify the way we see the usefulness of hospitalization, and we'll have more hospitalization. People will need more of a recourse to the technical platform in the future. However, and I'll finish with this, with the question of incentives. Yes, let's take home hospitalization. How can we have more recourse to home care when it's the alternative, the substitute to this problem of hospital accommodation? How can we develop that when we are going to be financed by what other hospitals lose? I don't know anybody who wants to cut off an arm and give it to their neighbor. No, we can be very generous in society, but I don't believe that this would actually work in the hospital system, in the healthcare system. If we can't find means of developing different practices and telling people that they're not going to lose anything if they reduce their activity, and telling patients that you're not going to lose out, obviously you're going to be paid for what's happening, and then with health insurance, you say that they're going to be gaining something. But we've got to have an intelligent system for that. We're in a binary system today. It's not the case today. There are savings that are being made for home hospitalization. This is possible. The cost is 4 times smaller with respect to the conventional day in hospital. But if we don't find the means of making sure that this difference is distributed differently, we'll never find any driving forces for transforming the current system. But it is the decision of the doctor, the duration of the stay in hospital. Yes, you're right. Today, it's not the director of the hospital who decides on that. No, that's right. But this is all the more important because, and it's something I want to underline this, it's all very well bringing people in on stretchers, but in my activity today, there are 2 categories of people that have to be taken into account. Hospital directors, because they have pressures, they have to provide indicators, and then you have the regional health agencies. Then you have the personnel, carers, and social assistants who worry about this hospital stay. So it's difficult. Now, I am myself a doctor. It's difficult for my doctor colleagues to understand this, whether they're in the private or public sector, because our training, the conception that we have of medicine, has always been, okay, if you're close to me, then that's fine. If you're away from me, then I'm worried. So that's the subject of the debate. So it's important to think about relevance. I'm like architects, when you ask them about building, it's very important to have the right location. My leitmotif is relevance, relevance, relevance. So if I caricature that, there are those who sleep in the hospital, those who don't sleep in the hospital then. For you, Jérôme, is it something that's fundamental in the debate that we're having today? I agree with what Elizabeth says, but I'm going to come back to 2 points. The real estate itself, the building. I've read the plans. Out of the 5 billion, 3 billion will be for a new building. I don't know if everybody knows that, but most of the hospital projects, the public hospital project, and this is a fact, financed 50% by public funds. Now, hopefully this money, we're going to use it differently. But the second point that I want to mention with respect to what Elizabeth is saying about professionals, this is what I saw yesterday. All healthcare professionals are completely open to these changes. There's no break, there's no obstacle. How can you explain that outpatient medicine is taking a long time to be accepted? Well, look at the practitioners that you have in the public hospitals and in the private clinics. Look at the differences. In terms of average duration, there's no difference. So the institution is responsible for this fact that outpatient medicine and surgery is taking so long to take on, to be popular. So there are people who are staying over the weekend in hospitals, for example. Well, for healthcare professionals in public hospitals and clinics, they are now trained for managing outpatient surgery. The second point, when I started my career 25 years ago, I started in the Alsace. I went back to the Alsace later on. There were patients who explained to us that having contributed all their life, it was normal that they should be able to be hospitalized as long as they wanted to be hospitalized. Now, all of that's finished today. Yes, it's finished, but when we were preparing the debate, you said to me yesterday that in some hospitals there were people who'd been there for a year, so it's not finished. Yeah, but that's a different case. We're not talking about the same people. But we're not just talking about infarctions or... No, but there's a question of volume and number. Those who said 20 years ago, I contributed all my life, I'm allowed to stay 2 weeks in the hospital, are not the same patients as those who can't find any other solution because they have multiple pathologies and they need multiple medical devices. So, coming back to what Elizabeth was saying, if you add to that in order to be able to do this, we need to revise the image of the hospital, including from the point of view of local policies. So this brings us back to the previous point. Let's imagine that a public hospital, because it's a public hospital, has to do everything. That's its role. It's just not acceptable and nonsensical. That means that the hospital system, when we talk about the path, the hospital life path, and Charles mentioned this, it's also a question of grading care, reorganizing things from a local point of view so that we can do things better and provide a better response and be less expensive. Just one last point. Now, when it comes to reorganization, and we're talking about a merged framework, with the help of the regional agency, we had to close an emergency ward and we had to wonder about other wards. Now, the immediate response was, we are allowed to have a hospital doing everything. We are allowed to have a maternity 10 minutes away. We are allowed to have emergency wards. That was the response. But when you look at things in details, the population that believed that it had this right actually goes elsewhere. Because in the hospital, in the local hospital that we're talking about, as long as it hasn't really changed, there is no outpatient surgery, there's no outpatient medicine, there are not the right technologies. And people are aware of this. Yes, just go on the internet and see how things are going. In fact, between the idea of I'm allowed, I have the right to, it's a democratic point, having a local hospital. And the reality, things are very different. And then you have the elected officials, and I've experienced this, then you have the elected officials who are ready to understand that a hospital that doesn't change is a hospital that is wasting money. We haven't really talked about the patient, we haven't talked about the healthcare pathway, and that's surprising. But when I was preparing this debate, I realized that today we do surveys on the color of socks. And there's been no big consultation in terms of what people want for their hospitals. Has there been a survey? And what about the responses? I didn't find anything on this. No. Perhaps it would be good to ask people what they want. Sorry, Jérôme, if I can just say something. I think that today people really don't understand all of the facts. This is what Mark was saying. In reality, perception is different from reality. The last surveys carried out focused on costs and focused on the sums that people believed a day in hospital cost. I think before we carry out a survey, so it's a survey, yes. A survey, I don't believe in surveys. I don't really believe in surveys. My job is to be an official translator of medicine. When you talk about outpatient medicine and when you carry out a survey, an outpatient surgery is somebody arriving in a hospital. Outpatient surgery is a notion that people have accepted. Let me just finish. And Jérôme, yes, I just want to say something. We've been talking about reorganization. We hear about these local hospital groups. We talked about horizontality, verticality yesterday. Our question is, what kind of articulation, what kind of structure are we going to have resulting from this? I think it's better to make sure that patients have a free choice. And I think this is more of a sociological evolution. And that's better than having something based on sectors, verticalization. This is where you go, this is what you follow, imposing on people. Now, do you understand? No, I don't really understand. So you're saying verticality, and then you do this, and it's more of a sinuous path. Yes, you follow the line. That's what I was saying. People have to follow the line. We must confuse the two. So I'm just translating the idea. Charles, I'd just like to come back to the patient and his knowledge of the system. Patients, they know that there is no complicated surgery for small acts. And patients say, they ask us to have outpatient management with everything that is programmed from A to Z, with exams and a service that is not invasive. I don't agree that patients should not be informed as much as possible about our healthcare system. Patients will help us to move forward quickly, and clinics communicate about organizational aspects. And this, notably for surgery, this is where we can have hospital problems. Now, fortunately, there are the patients, yes. So to get things to change. So your question was to transform things, and thankfully there are patients to help us do this. Let me just add a nuance. Sorry, Charles. You're in Nice. I have some facilities in Lozère, in the Haute-Marne, the Marne, in some lovely areas. But I do think that there's a lot of social and local inequality in terms of information. When you're in the Haute-Marne or when you're in the Marne, the understanding of reality is different. The knowledge is different. So I think that the reality, we've got to be careful when we're talking about it. And I agree with Mark, and we're saying this, the initiatives have been taken. It's true more so in private sector. So take a big group that's developed its technical platforms with examinations beforehand, consultations beforehand. Even if it's 200 kilometers away from your home, you agree to it because you've had the right consultation, you know that you're going to have the right monitoring afterwards, and you know that the surgery is going to be carried out in a safe environment by skilled people. That's what's important. The rest of that is just decoration. So it's going to be like in the United States. Let me just focus on patients. Patients, we shouldn't be talking about custard pie here. There isn't one facility project over the past 15 years that doesn't focus on healthcare and the medical project, and that doesn't place the patient at the center of everything. But the truth is much more complicated. So what I mean is that yesterday there was a debate. It was very important, and it was very exciting, this debate, about the involvement of the patient in the patient experience from a medical point of view. So this was, how do you, it was Michael Porter's idea of creating value. for the patient, and that's something that we need to focus on. We shouldn't just say put the patient in the center of everything, because we know what happens then. In fact, we've protected structures, we've protected the acquisitions, the buildings, but we haven't really focused on the patient. I'm sorry. The patient was like a billiard ball sent between different people. So, yes, the application is important. So putting the patient in the center of the problem is, of course, what everybody wants. But theoretically, when you ask a patient if they've slept okay, if they've had enough to eat, we don't talk about the real subject. The subject is, the value chain, value stream. You have this pathology, heart failure. What is important for you? And the facilities and the professionals need to understand that need. Have you already seen a surgeon provide enlightened information to patients? In other words, given the patient details and then operated on the patient. So we talked about custard pies earlier on. Let's talk about them again. And I'm talking about La Meuse and another area. Let's talk about innovation. Do you think innovation is what we need? We talked about artificial intelligence that's on its way. Didn't have any big concrete examples of that yesterday. What has to change from that point of view? I think that technological innovation is not the aim, but it is a means of modifying organizations and being innovative in terms of organization. For example, when I was the assistant manager in Grenoble, we had introduced a system to extract CO2 so that for patients suffering from chronic obstructive bronchitis. What was the result of this? The result was that you don't wait for the patient to suffocate and is sent to hospital in an ambulance and sent to intensive care. So we've realized that the saturation rate had to be followed. So we invent the notion of outpatient intensive care. So you've fallen into my trap. I did it on purpose. It's just to send you the ball back. Okay, so bronchitis, chronic bronchitis, but innovation, wouldn't it be to find the right application to stop people to smoking? Yes. In an ideal world, there wouldn't be anybody ill. No, but that's too easy, that answer. Stopping smoking is something that we can work on. It's something that we can envisage, no? Well, yes, I'm convinced of that, of course. It's not a complete utopia. So innovation, is it what Elizabeth was saying, making sure that there are fewer patients, that patients are kept for smaller durations? Isn't innovation too costly? Innovation must make it possible to enter into a healthcare system, to help with prevention, to follow patients remotely, and not having to accommodate them necessarily. But the difficulty of innovation is its financing. The person who invests first and foremost is not necessarily the person who's going to recover the overall saving for society. So this brings us back to the question of fungibility. So this is a very vast debate. But opposite me, I have the president of the CFMF, and he's looking at me. And this question is for you. Do you realize what's happening in Maubeuge? In Maubeuge, they're picking up customers outside because the hospital has general medicine consultations. So relocate the healthcare offer locally with GP consultation and taking over the remuneration of GPs. Is that a good idea? What do you think of it? I don't know this project, but it's probably a response to a need, and that is legitimate. So that's probably what the hospital has done. Also, it's an investment for the hospital. The investment is to have these early consultations, have GPs or a hospital ward that's open to GPs to make it possible to bring down and people coming in, the number of people coming into the emergency ward. So focusing on quality of healthcare. And I'm not just talking about the emergency ward with respect to the scope of activity that they have. But can GPs do this well? Can they take over what the emergency wards do? Yes. It's a way of getting over a number of problems. Let me come back to part of your answer. Now, of course, the idea is to say that the hospital does a lot of things that nobody else wants to do. When you have people that stay for a year, when you have conditions, long, painful illnesses, the hospital, it's a bit like, you know, it's the garbage bin. So can we talk about something that Jérôme didn't talk about? Isn't the hospital indispensable for all of that?
Yes, of course. Of course. Well, that's a bit simplistic to say that private hospitalization doesn't respond to the needs of a certain number of patients who will have to go to the public hospital. No, I think that's too simplistic. There is a problem of medical and social crowding, and we continue to pay 1,200 euros per day when we're lacking beds, and we need these SSR beds. There are only 10% of long stays that are justified by medical indication. 90% of the long stays are justified by the absence of any system or availability of medical, social, healthcare means to take care of these patients. We used to call them alternatives. For example, home hospitalization and other options. We have a problem of overall regulation of the system, which means we keep the patients in the public hospital because we don't know where to send them. Now, let's ask the private clinics. Do you have the same types of figures, 90%, 10%? Some of the people occupying your beds? Well, for long stays, yes. We're talking about a tiny margin, but thank you for saying that. But I think we have to stop opposing the private clinics and the public hospitals and say that private clinics don't take certain types of patients. But let's admit it, we only cover between 2 and 10%, and the public hospital covers 90% of the patients. So it's a false debate. What about home hospitalization? Well, I would say to Charles that we need to work together to make sure that the hospital system in Nice becomes more effective, because this would maybe solve a fragment of that 90%. Maybe we could find better solutions. What about the example of Maubeuge in the north of France? Well, I don't think it's a good solution. I don't think that's the right solution. And what I've read about the solution in Maubeuge, it's not the examples that I evoked earlier with a medical desert. And so where there could be a legitimacy of a search for solutions, yes. But in places where we don't have GPs, as a general rule, the hospitals who are proximity hospitals also have a hard time finding hospital doctors. So it's not those hospitals that will be able to fill the gaps. So usually, if you have a lack of doctors, it's true in both the private practice and the public hospitals. Now, earlier, Mark was giving these interesting examples. I think you have to be very careful with the definition that we give to innovation. Innovation, for years, we thought it was therapeutic innovation. And then we saw that it was becoming technological. And today, and I'm delighted, many reports have been issued on the subject, we're observing that this innovation can also be organizational innovation, strongly based on technological innovation and therapeutic innovation, which we've not been successful in doing in France for years. We focused on therapeutic and technological innovation, but we never were able to change our processes and our organizations. So this is why it's extremely important to really integrate ambulatory care and home care and home care professionals in this transformation of our organization so that the patient's healthcare path is not something that's disorganized. It has to be organized and anticipated. If 90% of the patients remain in the hospital, and this really strikes me to see when we have people hospitalized at home, we can't seem to anticipate these needs. When we see that a patient has a cancer who is deteriorating, obviously the end is near. And when the end is near, I see patients who remain in the hospital. And then we receive a phone call to say, well, no, you should intervene this afternoon for hospitalize him at home. And don't worry, we've taken away his morphine and he's going to die. That's really a lack of responsibility. Well, he could have stayed 6 weeks at home instead of 3 weeks at home, because when they come home, often they feel better and they have a more peaceful end of life. We're absolutely unable to anticipate. We don't do it. We don't forecast anything. We don't look ahead. So the 3 billion that we were referring to earlier, rather than building hospitals, walls, etc., we need to finance this change, this policy of change and organizational change. We're talking a lot these days about transformation, and beyond these semantics, is transformation an adaptation or a constructive destruction? Well, let's come back to the conditions of innovation. As I said earlier, the conditions of ambulatory care. Let's trust each other. We need to be trusted. Trust us. Okay. In the clinics, how many clinics do you have? We have 100 clinics. Are they all as well managed? Well, I said that there were a certain percentage that were suffering from a deficit, but let me look at our 2 hospital directors. Out of all the hospitals in France, let's focus on the large hospitals. No, not the big fat directors. No, the big hospitals. No, excuse me. So there are 30 university hospitals. Okay. Now, it's not an easy question. Are there public hospitals that are models, or are you all at the same level? We're all concerned by the same issues. You were evoking, Jerome, the question of transformation, which is a partial response. This question of transformation will be radical and will concern us in this wish that you've expressed for an approach that's more connected. When we start financing the path. So during the healthcare path, one of the either public or private actors will be financing the care. And here this will be a huge transformation, which will be descriptive, as we say, in the way we exchange and discuss and finance the patient's care. Now, management. Do you really have the weapons that you need to manage your hospitals? Are you equipped well to manage your hospitals? Well, all of us, I think, have to deal with the same type of problems that are similar in terms of medical demography, with more or less. So demography means that some hospitals are suffering from a deficit, and it's the type of region as well? No. I think there is a size effect, certainly. Some hospitals are too large, and they generate economies of scale, and they require transformations to improve care processes that are very numerous. So we have to really map all of these processes. And then hospitals that are too small don't reach a critical size that's sufficient to finance their structure and especially their technical wards and equipment. So between 400 and 600 beds, this is about an ideal size, which allows the hospital to be in a good position. But to answer you more directly, yes, we have the means to manage or improve the operation of hospitals, including public hospitals, because we have a lot of margin of maneuver for the internal operation of the hospital. Let me come back to banal payment. We have the banal payment is someone, maybe the hospital. That's the example that you were describing in Maubeuge. Now, in CHAM, you know, we like to dream here. CHAM is a magic wand sometimes. So I appoint all four of you now as ministers of the hospital in charge of reform, and we're going to stop saying it would be good to do this and good to do that. Let's give you each one. What would be your first measure that you would take if you were in charge of the hospitals? Would you privatize? No. Two measures. One, consideration. Two, and focus on the patient healthcare path. That's not a conclusion. That would be my first measure. If I've just appointed you, you're the new Minister of Hospitals. Okay, consideration and then the healthcare path. Well, parcours or the patient healthcare path, we just explained that. Okay. Elizabeth, if you... Well, everybody knows that I don't recognize this approach where you appoint people only from the elite ENA school in France. I believe in relevance based on quality, and the first thing that I would do to apply what I was evoking, the proper usage of hospital beds, when a patient is admitted to the hospital after the medical checkup, obviously, you need to respond to two questions. This patient that I've just examined, for whom I've carried out my diagnosis and requested a certain number of tests, does he need constant surveillance because his life is in danger? Yes, no. Second, does he need any type of operation or diagnosis in our technical wards? Then I would say yes, no. If it's no, then we would orient his path and see how we could not just put him in a hospital bed and find a better solution for the patient. This would be a mandatory measure when each patient is admitted, and I would make this approach systematic. Charles, what would you do? Would you try to improve the wards that are not operating properly? I think we would need to change the pricing and really focusing on quality. We need to go away from the TAA to the TAQ. So instead of payment per act, it would be payment for quality. We're driven by our income. Unfortunately, we have to focus on what is coming into the hospital. So volume of business, if you will. I know this might shock people to hear this, but so we methodically fill out every year these income analyses, but we're not motivated by high-quality care when we're hospital managers. Now, I'm not talking about the healthcare professionals, obviously, who are caring for the patients. So this really does not encourage us to focus on quality, not the softness of the sheets or the quality of the meals. We need robust medical indicators focused on the care, patient care, relevance of the medical treatment. And I think hospitals would change a lot faster than they're changing today. This could represent 0.13% of the hospital budget in Nice. Well, what would I change? I'd have two objectives. One final objective, but the first two would be frugality and agility, and the third would be sustainability. Behind this, there's a question of management, organization of the teams, leadership, a real proactive desire for transformation, to understand, to make sure that we're going in the right direction that makes sense, and that we organize ourselves so that this makes sense for all of the healthcare professionals, while emphasizing that hospital staff have already been able to commit in these terms, frugality and agility, in view of a certain sustainability. And I truly believe in the introduction of technological innovation. It's not the perfect solution for every need, but I think it's absolutely indispensable that hospitals and healthcare professionals have access to the market just the way industry must have access to the market. if we don't have these tools, we won't be able to start restructuring our organization. So you were talking about frugality and agility to the patients. That's not a notion that's easy to defend, but so you said consideration and the healthcare path, those that you hospitalize in the beds and those that you don't hospitalize. So you talked about the TAA, and now you've invented the TAQ based on quality in CHAM. So there are 5 minutes and 34 seconds left. I'll give you each 1 minute for your conclusion. So, Charles, over to you. Well, the hospital has a great future ahead of it. We have wonderful projects to work on, as we've just seen. I think we can, and I agree with my colleague here in terms of confidence and consideration. I think hospitals are ready to change. They've always showed that they need support, yes, and the public authorities should support this transformation approach, which is necessary and important for our system. And indeed, we should try to include the patient and the private practice professionals who we haven't talked about much in this debate. The hospital can't do everything. It should be irrigated and connected to the private practice professionals. Jérôme? Healthcare professionals are not just in this profession by chance. Most of them have a vocation. And thanks to this, they've always adapted. They've always innovated. They were the first to use cars, telephones, smartphones. They've always been the first. And the Code of Ethics, it says to give the best health care with the best therapeutics and tools that exist. So this is already a fabulous opportunity. So the responsibility to change and transform and adapt things, as we said, is ours, the people who are here in the room. And let me go back to what I said with respect to consideration. We need a shorter time scale. It used to take 4 years to be able to set up telemedicine. 4 years. We need to do things faster. We need consideration, trust, and confidence. And as I said, it's a bit utopian to talk about love, but I would say let's be kind and benevolent with each other. Mark, I think we're to a certain extent in a situation of product designers who have all these fabulous ideas, who know how to do a lot of things, but maybe what's lacking is the link with the end user. So I think we need to rethink our organizations, certainly around this notion of the end user. And I agree with what was said. We know how to use the intelligence of the hospital staff, their involvement, their desire to do things well, which is obvious in times of crisis and in their day-to-day work. We need to know where we want to go to set our course, a course that makes sense, and I think this is how we will find the appropriate solutions. Elisabeth Huppert, you were the former health minister. You've worked in the private sector, and you also work in the hospital sector, and you're the perfect person to conclude. Well, thank you for that honor. In 1 minute, yes. Well, I'll be quick. You know, I'm a very, I like to simplify things. We said, the question was, hospitals, healthcare establishments, what for? Well, healthcare facilities are in charge of health tomorrow, so we're broadening the meaning of something, and this is in line with the national healthcare strategy that is being elaborated today. So we need to broaden the spectrum of the establishments, not from a territorial standpoint and saying, I'm going to eat up the small hospitals. No. The second thing, we talked a lot about the patient healthcare path, and we need to be very prudent, very careful with this notion of different sectors and any domination of certain actors. And let me repeat again, and Charles said this as well, relevance based on quality. And it's the patient who is indeed the core element here. And thirdly, I think that healthcare facilities with their obligations. Let's not forget a continuity of care, quality approach, and safety, which are drastic. This will open up to home care, home hospitalization, and also these healthcare centers that we call maisons de santé in France. I think we could have a harmonious link with what we're doing in the hospital world. And tomorrow, this is what...
So I don't have time to say anything else. I didn't want to cut you off. I wanted to thank all of our guests. It's not easy, of course, to answer all these questions. It's also not very easy for me to coordinate, but it's extremely serious things for you. So I wanted to thank the organization of the CHAM, which more than ever deserves quite a bit of praise. And I also want to say thank you to Guy Valencien, who's our host every year, which is not incompatible. I will also we'll see you next year at CHAM, and I hope that they'll give me another debate, the information to the public. And thank you, and enjoy the rest of your day.